Well,
Yeah.
thank you for agreeing to this interview, and your cat also agreeing to be here.
Not agreeing to be here.
So cute, nevertheless. Could you please introduce yourself with your name along with your pronouns?
Sure. I am Kristin Colley. I use they, them pronouns.
Awesome. And could you please give us some background on your education, how many years you've been doing the work that you're doing, what is the work that you primarily do?
Okay. My education, I got a BA in psychology right out of high school. I graduated in 1994 and had a baby and started pursuing midwifery, kind of based on that experience. I went to midwifery school at Seattle Midwifery School, which is now the program at Bastyr, but back when it was its own institution in, I think, 2001 to 2005. So my formal education is in midwifery, and I'm a licensed midwife, but the work that I do, I just like scratched the surface in midwifery school. I'm a fertility specialist, and I specialize in helping queer and trans people and single parents by choice to conceive. So I do a lot of fertility work. I do in-home IUI, sperm washing. I teach a lot of classes. I do a lot of kind of, I really believe strongly in bringing people together when they're going through the life transition of becoming parents. So I've always taught classes and led support groups, but kind of one of the pivots that I did during the pandemic is starting a pregnancy program so that I'm taking people all the way through their entire pregnancy in the first few months after birth, in a group model, so they can really develop and deepen relationships, so that by the time they're really in the thick of it with a newborn, they really just have a lot of interpersonal support. And then of course, you know, I'm facilitating all those groups and you know, sharing knowledge, educating, and things like that. So they, even if families aren't in midwifery care, they're getting some midwifery care from me.
That is fantastic. And you mentioned specifically queer and trans folks and families and single parents by choice. And I believe you also work with polyamorous couples, is that right? So you kind of just go the whole spectrum. And
yeah, well, and cis hetero couples, you know, cool. I mean, I work with everybody.
You have everyone, that's fantastic. Yeah. And do you, I'm assuming I know the answer to this, but do you get the sense that there is really a large need for this community, especially with the pandemic, I'm sure, but with marginalized folks undergoing a really heteronormative space related to getting pregnant and delivering a baby, do you get the sense that there is really this need for community and connection? And you mentioned that interpersonal support. Yeah.
I think that, I think it never becomes so apparent that humans are social creatures and we are not meant to navigate new parenthood alone. I think that element of what it is to be a human being is never so apparent than it is when we have a baby and bring, you know, form a family, bring a baby into our lives. And that's across the board. When you add the additional, you know, implications, stress, you know, legal navigation, just being if you're not part of the kind of mainstream, then going through such a massive life transition and not having a lot of reflections can really enhance the isolation that people feel. So, and I think that most new parents feel really isolated. That's why we have, you know, the PEPS program in Seattle, and, you know, why people look for new parents groups. So yes, that experience I think is very much compounded for queer and trans families and single parents by choice. And so being able to offer this specifically in kind of a focused, you know, a format that's focused on queer and trans family structures normalizes the experience. It's like people walk into the room, whether it's a physical room back in the old days or a Zoom room, and just like what people describe to me is I immediately felt my whole body relax and just felt like, oh my God, this is so comfortable. Like this is, I don't even know these people, but it's just a really a felt sense of difference between walking into a room of cis het folks or walking into a room full of other queer folks. And just feeling, I mean, I think that not having to explain yourself, just having like a common understanding of what it is to walk through the world. And I know the same thing happens around race, ethnicity, you know, different cultural backgrounds. It's no wonder, you know, as humans, not only do we need each other, but we also form social groups around those commonalities. Because there's so much that's important, that's unsaid, that's unspoken.
That unspoken lived experience. Absolutely. Yeah. I think that's such a wonderful service that you provide, and certainly unique. You know, I wish that there were more practices like yours, but and I'm sure that there are, right? The world is small when you find out other practitioners who are similar to you, but it's still definitely not, as you put it, mainstream. So with that kind of in mind, like taking a better look at what you do every day, you mentioned Inhome IUI, facilitating these awesome community courses for new parents and folks as they go through their experience of pregnancy. What is kind of your clinical practice? Like, what do you see most commonly clinically in terms of the patients that you work with?
Most of the clinical care that I'm providing is around conception. So intrauterine insemination is the main kind of clinical touch point that I have. I mean, every now and then I'll draw somebody's blood, and every now and then I'll catch a baby and everything that's involved with that. But for the most part, it's insemination. And I can talk about that a little bit, because I find that people will often note, that's the most comfortable pelvic exam I've ever had, or oh my God, that was so, like, thank you for talking to me, for explaining what was happening. Like, sometimes I'm shocked by how low people's expectations are. I feel like all I'm doing is paying attention, going slow, getting multiple points of consent throughout an exam. I get consent before I talk people through, this is what the process is going to be. I tend to, I'll let people know, I tend to talk people through everything that's happening. And if that's too much for you, just let me know and I won't talk so much. If at any point anything's uncomfortable, just say stop, even just raise your hand, make a noise. I will freeze right where I am and figure out how to make you comfortable. I get consent before I touch a person, you know, let me know when you're ready to start. I let people, like, I give people anticipatory guidance all along the way. Like, okay, here's the speculum, and then they can feel that the speculum is there. I'll say, you know, take a deep breath, blow out that pressure that you feel. You let me know when it's okay to keep going. So like, I haven't even inserted the speculum yet. I'll let them know, like, if I'm really having to reach to find the cervix, I'll let them know, you know, you're going to feel a lot of pressure here in the back. Your cervix is really high today, or you'll feel kind of something off to your left. It's over to the left. So I just kind of talk them through to kind of translate what they're feeling as they're feeling it. And then I also get consent before I place the catheter, before I place the sample. And also as I'm removing the speculum, like, okay, you're going to feel me tilting the speculum as I bring it out. Also noises, I skipped that part in the description. There's often a click when you click open the speculum, and I'll let people know, okay, there's going to be a little click. So I'm just thinking about all the different things that, you know, the sounds, the sensations that a person's going to be taking in, and, you know, letting them know and keeping them present with what's happening. Of course, I ask people, is there anything you want me to know that would make this exam more comfortable for you? Any specific words you want me to use or not use? So we have that kind of, you know, pre-exam conversation. Yeah, so that's what that looks like.
Yeah, and I think that's a great point to touch on, considering how dysphoric pelvic exams can be for so many queer and trans folks, and why that by itself contributes to the health disparity we see with transmasculine folks in particular not getting their regular pap smears and whatnot, because they don't have someone providing well, it sounds really trauma informed with how you're describing it, and how that should definitely just be the baseline. And those are all practical things that all providers can implement. And it also speaks to with what you said about the bar being so low, is that when it comes down to it, like we don't necessarily do that much different clinical stuff maybe than what other folks do. It's just we do it in a trauma informed way from an inclusive lens, which really should be the baseline. So thank you for sharing that. So you kind of already touched on this, but further discussing your specialty, how does your passion for gender inclusivity and activism impact your midwifery practice?
Welcome to my world at dinner time. All my kids grew up and left the house, and I had to get a cat so that I would, like, you know, still feel like life is normal. It has 100% informed my practice. When I got out of school, I wanted to work with the queer community, and guess what? Our midwifery care starts before we're pregnant. Right? Because most of us, not all, but many of us need assisted conception. And the, you know, people who don't know anything about donor conception might think, well, gosh, can't you just get a turkey baster and, you know, what's the big deal?
Right.
There are legal, you know, implications. There are implications for transmission of STIs. And not everybody knows somebody that can give sperm to them. And when you're working with frozen sperm from a bank, your chances double by doing intrauterine insemination. So having a provider that can give, you know, a culturally appropriate trauma-informed IUI can double your chances of success. And then that like has all kinds of financial implications, mental health implications, because trying to get pregnant is really hard. So once I got into the practice, I realized, okay, preconception care is a huge part of what I'm doing. And I ultimately stopped going to births because there's a lot of midwives that provide fine care during pregnancy and birth who don't do preconception care. And I think I ultimately decided I could do more good for more people by focusing on preconception care and the adjunct services. I mean, I facilitated support groups since before I was a midwife. So just putting those skills to, you know, here's these skills, here's these hands and this mind and this life, and how can I best serve my people? And that's how it's turned out.
I love that. I think actually, I'm just remembering how I ended up getting connected with you through a mutual patient. And I was doing a workshop about pelvic floor. And I just had folks go around the room, introduce themselves and why they're here, what they want to learn. And I think the way they phrased it was, my partner and I have just achieved a miracle that is queer pregnancy. And that's exactly what you're describing, right? It is hard. It's hard for a lot of folks, but it's especially hard when you compound those layers of microaggression, marginalized stress, etc. When you're talking about like unique needs for queer and trans folks in the perinatal health space, you've already touched on a lot, but are there any others that you consider, if you were to take a midwifery student under your wing, who maybe hasn't been exposed to such a large volume of a niche practice before, are there any specific needs that you think are most important to be aware of?
Can you narrow your question a little bit?
That's okay.
All of it?
I think you've already touched on quite a lot. So for example, I guess I'm not a midwife, but so clinically, if I were to have a transmasculine person come to my practice and they have vulvar area pain, I'm going to consider like their hormone use and how testosterone can atrophy the labia and things like that, which might not be something I consider as strongly for someone with for a cis woman. Are there any clinical specific like physiological needs that you might factor in?
Well, in order to conceive, I mean, testosterone is not adequate birth control, but a lot of guys don't cycle on testosterone and need to stop testosterone in order to get pregnant. So really it's about, I mean, I guess the main thing is that a history of being on testosterone doesn't necessarily impact your ability to get pregnant. Like once you're off of T and your body's cycling again, you're kind of in the same place as anybody else. You know, and including if you have other issues, like if you have PCOS, then you're still a person with PCOS. If you're 35, you're still 35. Which 35 is not nearly as big a deal as 40. I mean, I would say a lot of what I do in my practice is like breaking down the available research and really making sure that it applies. There's a lot of information and ways of practicing and ways of speaking in the fertility world that are I'm trying to think of the word, just inflammatory when they don't need to be, such as being 35. Like most of my people are over 35. It's really not a big deal till you're over 40. And I'm going to tell you how to offset the effects of age. Timing, you know, how inseminations are timed. People are much more involved in the timing of their inseminations in my practice because I'm following the individual, and that requires the individual to be involved. So yeah, why don't I hone in on that just a little bit? So our bodies tell us when we're ovulating if only we know what to look for. So mid-cycle, when you ovulate, your estrogen levels get really high, which makes the cervix soft and open. It makes your cervical fluid clear and or stretchy. And those symptoms will keep increasing and increasing until the egg releases, and then they'll go away. There is a measurable span of time between the actual release of your egg at the peak of those symptoms and a surge in luteinizing hormone, which you can pick up on a urine test kit called an ovulation predictor kit. The package instructions, the fertility clinic protocol, they all just tell you test once a day, come in the next day, get your IUI. That's like hitting the broadside of a barn, which would be fine if you were using fresh sperm and just doing self-insemination or having intercourse. But with intrauterine insemination, it's best to do it within 12 hours of the release of your egg. So that means testing twice a day, looking twice a day. And if you're able to do that, you can like, most bodies that are ovulating strongly and have good fertile health will have a predictable window of time from that positive on the urine LH kit to the peak estrogen symptoms. And then that's how we time the insemination. If it's 12 hours after for you, that's when we're going to do the IUI. If it's 24, 36, if it's the same time as you're positive, then let's see if there's any preemptory signs so we can have some more ease in scheduling. But otherwise, I'm going to come when you call me. So that's not something that's done in clinics. And I would say specifically for trans men who have a lot of dysphoria around their genitals, they're not going to be wanting to look at their cervix and checking their fluid all the time and that kind of thing. So it gets really individualized at that point. We might just be looking at the difference between when they get a positive on a urine kit and when their basal body temperature goes up, which is post-ovulatory, and kind of looking at that time frame. And if it's really wide and we need another sign, then I'm going to talk to them about other sort of more secondary fertile signs. What kind of sensations are they getting, which can be before, during, or after ovulation, but what are you feeling around ovulation time? Do you have a day when your sex drive is higher, when your appetite changes? What about mood changes? Hey, come on. There's also your saliva with peak estrogen. Your saliva forms a fern-like pattern.
Oh, interesting.
So sometimes I'll set them up with they sell these little personal microscopes that you can look at your saliva. So, you know, we get creative with tracking fertile signs. And I tend to be honest with people, like, here's what we know from what you've been able to collect from your body. Here's what we don't know. And here's what we can do based on what we know. It might mean that we do more than one insemination. Go on, she's really hungry. It might mean that we do more than one insemination, or we just like time it halfway.
Yeah.
You know, so
yeah.
She's really hangry.
She's hangry. I think we're being told we have to close soon, and I know that you have to head.
Yeah. Yeah.
I would love to comment on that, but it seems like we have short on time, so I'm just gonna ask you one last question.
Go ahead.
So you obviously we're connected, and I know that you have other connections in the community. What do you think public health professionals would benefit from knowing about the kind of care that you provide so that they could better serve the LGBTQ+ community?
I guess what I want them to know is that if you have anyone who is conceiving via donor conception, whether it's somebody they know, somebody they don't, but like any queer and trans folks that are conceiving, even cis het people who are either using donor sperm or using a sample that was, stored before a vasectomy or cancer treatment or whatever, there is an in-home option. My practice is totally evidence-based. In fact, I just wrote a book, and the book is focused on queer families. It's called Queer Conception, the Complete Fertility Guide for Queer and Trans Parents to Be. But like I said, I also work with straight folks, and I'm very much have an evidence-based practice. So what I tell my clients is I can speak woo, but I can be anywhere on that spectrum as it makes sense to you, but I'm always going to give you the evidence. And we didn't even talk about anti-fat bias.
Right.
So that's another thing that I take very seriously. And really, if you have the good nutrition and you're moving your body on a regular basis, I'm really not going to be focused on your weight, and I don't think you should be either. And people that do want to focus on their weight, I'm constantly saying, check in with your mental health, make sure this really feels life affirming. So anyway, I guess what I want people to know is that I specialize and I teach other providers, and there's nobody else that does what I do, how I do it. And it's hard to toot your own horn, but you have the worldwide expert here in Seattle. So if you're in Seattle, great. And I work with people all over the country, and I know IUI providers all over the country. So today met with somebody in LA who's going to get her IUI locally, but I'm providing all of her other care.
Wow.
Ordering labs and helping with timing and that kind of stuff. So you're not limited to Seattle.
So there are options.
Yeah, totally.
Well, thank you so much again for your time. And I'm sorry to your cat for making them wait for dinner. But I really appreciate your expertise, your perspective. And I think that this is really going to help the students gain even more knowledge. So thank you.
You're so welcome.